Usually, when we talk about a medical diagnosis, there is this expectation of absolute precision. It feels almost like engineering.
Mm.
Like if a patient breaks their arm, that x-ray goes up on the screen, and you see this stark, jagged white line right through the bone.
Yeah.
The clinician points at it and just, well, they know exactly what to do. The problem is visible, and the treatment pathway is clear.
Yeah, that kind of binary diagnostics like broken or not broken is incredibly comforting to the clinical mind.
Hmm.
But I mean, it creates this false sense of security when we move away from structural trauma and step into the actual biochemical realities of a sick patient.
Which brings us to a scenario that happens on the wards, literally every single day. You draw blood from a patient battling a severe infection, you order a nutritional panel to see what resources their body needs, and when the lab results come back, they're, well, they're effectively lying to you.
Exactly. You are looking at a diagnostic mirage. The numbers on the page simply do not reflect the biological reality happening inside the patient's tissues.
So to figure out why the labs lie, we are doing a deep dive into the textbook Nutrition, Immunity, and Infection, edited by Philip C. Calder and Anil D. Kulkarni.
It's an incredible resource.
Yeah.
And the core framework we're unpacking today is the nutrition, immunity, infection triad. For anyone studying medicine or managing patient care, grasping the mechanics of this triad completely reshapes how you view a lab report. Because the fundamental premise here is that the immune system is arguably the most metabolically expensive machinery in the human body.
Okay, let's unpack this because when we say metabolically expensive, what does that actually mean at a cellular level? We often picture the immune system as this standing army just waiting around, but it actually has to physically build its weapons from scratch when a threat appears.
Yeah, think about the sheer scale of the biological response. When a pathogen breaches the body, the adaptive immune system has to undergo massive clonal expansion.
Right.
So a handful of specific T cells and B cells recognize the threat, and suddenly they have to multiply into millions of functional cells within days. Millions. And that requires an astronomical amount of ATP for energy, plus a continuous supply of raw materials. I mean, amino acids for protein synthesis, lipids for new cell membranes, and specific micronutrients acting as enzymatic cofactors.
And if the body is malnourished,
That manufacturing pipeline just grinds to a halt. And clinically, it's so important to remember that malnutrition doesn't just mean starvation. It encompasses specific micronutrient deficiencies, protein energy malnutrition, and crucially, overnutrition, like obesity.
so to really understand how those states of malnutrition break the system, we first need to establish exactly how the immune system utilizes specific nutrients to build its defenses, like the baseline.
Exactly.
Let's start with the innate immune system. We hear a lot about pattern recognition receptors or PRRs, like toll-like receptors. What are these doing, and how do nutrients factor in?
Well, the innate system is your rapid, non-specific first responder. Toll-like receptors act almost like biological barcode scanners.
Barcode scanners, okay.
Yeah, they sit on the surface of immune cells and scan for specific molecular barcodes that only exist on pathogens, things like lipopolysaccharides on the cell walls of certain bacteria. When the scanner reads that barcode, it sounds the alarm.
But before those scanners even come into play, the pathogen has to actually breach the physical barriers, right?
Yes, and that is where vitamin A becomes critical.
Vitamin A, which is funny because it's often casually referred to as the eye vitamin, but in this triad, it acts as the primary architect of the epithelium.
It governs the cellular maturation of epithelial surfaces. So the skin, the respiratory tract, the mucosal lining of the gut. When a patient lacks vitamin A, the delicate mucus-secreting cells that trap bacteria cannot mature properly.
It's just failed to develop.
Right. Instead, the tissue undergoes squamous metaplasia. The cells harden, they flatten out, and they literally stop producing mucus.
Wow. So the barrier essentially dries up and cracks, leaving an open door for pathogens. So if we use a medieval fortress analogy, vitamin A is the mortar keeping the stone walls intact. But the textbook points out that squamous metaplasia isn't the only issue. Vitamin A deficiency also paralyzes the immune cells themselves, specifically the neutrophils.
Yet, neutrophils rely on a process called chemotaxis, which is following a chemical trail to the site of infection.
Yeah.
And then they destroy the invader using a localized chemical explosion called an oxidative burst.
Right.
Without vitamin A, both of those functions are severely blunted. The neutrophils cannot navigate, and even if they somehow find the target, their ammunition is totally compromised.
So the soldiers are blind and unarmed.
Exactly. Furthermore, dendritic cells lose their ability to stimulate Th1 cells, which are absolutely required for mounting a cell-mediated defense against viruses.
Okay, but if vitamin A is ensuring the cells are built correctly and have their ammunition, how do they survive actually using that ammunition? You just mentioned the oxidative burst. If an immune cell is blasting a bacteria with toxic free radicals, how does it keep from destroying itself in the crossfire?
That requires vitamin E, which operates as a specialized lipid-soluble antioxidant.
Hmm.
Immune cell membranes are packed with highly fluid polyunsaturated fatty acids,
Which are vulnerable.
incredibly vulnerable to oxidation.
Yeah.
When a macrophage unleashes an oxidative burst to kill a pathogen, it is essentially firing a biological flamethrower.
Jeez.
The free radicals generated can easily bounce back and ignite a chain reaction of lipid peroxidation that would just melt the macrophage's own cell membrane.
So keeping with the fortress analogy, vitamin E acts like the rust proofing on the soldier's weapons or like a heat shield on a spacecraft re-entering the atmosphere. It embeds itself directly into that fatty membrane and absorbs the intense heat of the oxidative burst.
Right, taking the damage so the structural integrity of the cell survives. And what's fascinating here is that this mechanism is so effective that replenishing vitamin E in older subjects has been shown to physically reverse age-related immune decline.
Wait, reverse it.
Yeah. By stabilizing those membranes, the immune cells regain their youthful functional capacity, leading to significantly improved resistance to pathogens like Streptococcus pneumoniae in the elderly.
That's amazing.
Mm.
But I have to push back a little here. Knowing that these vitamins are the structural foundations and the heat shields, it's really tempting to think we can just flood the system to build an indestructible fortress. Like if a normal amount of zinc or selenium gives you a functioning immune cell, would flooding the body with them turn it into a super soldier?
The clinical data pushes back hard against that idea. The biological machinery operates on an optimal threshold, not an infinite sliding scale.
Okay.
Let's look at selenium. At baseline, selenium is brilliant at modulating the epigenetic regulation of macrophages, promoting a protective Th2 response against specific parasitic infections, like the nematode H. bakeri.
Right.
But the benefit of supplementing selenium or zinc primarily applies to individuals who are actually deficient. Giving massive pharmacological doses to a replete, healthy patient does not exponentially boost immunity.
It doesn't scale up.
No, in some cases, oversupplementation can actually cause toxicity that impairs immune function. The body wants homeostasis, not a flood.
So if the system breaks down when we lack these specific micronutrients, what happens when we look at the macro level? Because knowing that optimal micronutrient levels protect the host, we must examine what happens clinically when caloric intake shifts to the extreme ends of the spectrum.
Right, obesity and anorexia.
Exactly, because the immune system's reaction in these states is entirely counterintuitive.
Obesity fundamentally rewires the immune landscape. As adipose tissue expands, it stops being a passive storage depot. The fat cells begin to suffer from localized hypoxia. They are literally suffocating. And they send out distress signals.
And the immune system responds to that.
It triggers a massive influx of immune cells directly into the fat tissue. The resident macrophages undergo a profound phenotypic switch. They shift from an M2 state, which is tissue-repairing and anti-inflammatory, to an M1 state, which is highly aggressive and pro-inflammatory.
This means a patient with obesity is walking around in a constant state of systemic low-grade inflammation. The alarm bells are always ringing quietly in the background. But does that background noise actually translate to a compromised response when a real threat, like a virus, arrives?
It severely distracts the adaptive immune system. The textbook details this elegant animal model to prove this. Researchers took cohorts of obese mice and lean mice and initially primed them with a less severe H3N2 influenza strain.
Okay.
Later, they challenged both groups with a lethal H1N1 strain to test their immunological memory.
And the results of that study are staggering. 100% of the lean mice survived because their adaptive immune system remembered the previous exposure and mounted a rapid cross-reactive T-cell defense.
But 25% of the obese mice died. And the obese mice that did survive had viral titers in their lungs that were 10 to 100 times higher than the lean mice.
100 times higher.
Yeah. The baseline inflammation caused by those M1 macrophages in obesity essentially deafens the adaptive immune system. It prevents the formation of effective, long-lasting T-cell memory.
So the system is so flooded with false alarms from adipose tissue that it fails to organize a targeted response to the actual virus.
Precisely.
Which brings us to the bizarre paradox on the exact opposite end of the malnutrition spectrum. anorexia nervosa. In a state of severe protein energy malnutrition, the body is completely starved of the ATP and building blocks we talked about earlier. You could assume the patient's immune system would just instantly collapse.
That is the logical assumption. But clinical observations reveal something astonishing. Patients suffering from severe anorexia nervosa are surprisingly free from common viral infections and hospital-acquired bugs, at least until the very late stages of their debilitation.
Wait, so severe starvation might actually mask the symptoms of a viral infection because the body literally doesn't have the T-cell energy to mount a fever or inflammatory response.
If we connect this to the bigger picture, it's all about how the immune system triages energy. We have to recognize what clinical symptoms actually are. When you get a virus, the fever, the profound fatigue, the systemic body aches, those are not strictly caused by the virus itself.
Right, they're the immune response.
Exactly. Those are the manifestations of your immune system working. Generating a fever requires a massive burn of calories. The body elevates its core temperature to make the environment hostile to the pathogen.
But a patient with anorexia doesn't have the caloric reserves to burn on a fever. The energy simply isn't there.
Right. During extreme starvation, the body executes a complex neuroendocrine adaptation. It deliberately downregulates the number and intensity of memory CD8 plus T cells. It essentially unplugs the alarm system to save electricity.
Wow.
The viral pathogen might actually be present in the patient's body, replicating at a low level, but the host cannot afford the energetic cost of fighting it. Because the immune response is blunted, the clinical symptoms of the infection never manifest.
That is a terrifying biological compromise. The virus is there, but the body is ignoring it just to keep the brain and the heart running for another day.
Yeah.
So we've seen how nutrition dictates the immune response. But here's where it gets really interesting. This is a two-way street. Once an infection takes hold, it actively hijacks the host's nutritional status and physiology.
And this phenomenon is where clinicians are most likely to be led astray by routine lab work. When an infection begins, activated macrophages release a cascade of pro-inflammatory cytokines, specifically interleukin-1, interleukin-6, and tumor necrosis factor alpha.
Okay.
These signaling molecules travel directly to the liver and trigger the acute phase response.
The liver essentially acts as the body's manufacturing hub. During peacetime, it's churning out transport proteins like retinol-binding protein, which carries vitamin A through the blood to the tissues. But when those cytokines hit the liver, it abruptly shifts production to wartime manufacturing.
The liver stops synthesizing those nutrient transport proteins and reprioritizes its amino acids to build acute phase proteins, most notably C-reactive protein, or CRP.
Right.
As the transport proteins disappear from circulation, the micronutrients they carry have no way to stay in the bloodstream. They retreat and hide inside the liver and the surrounding tissues.
Which means if you draw blood from that patient, the serum levels of those nutrients will look dangerously low. The lab report will scream, "deficiency," even though the patient has perfectly adequate stores of vitamins locked away. The acute phase response is effectively hiding the gauges.
This is why you must understand the specific thresholds of the acute phase response. If a patient's CRP rises above 5 milligrams per liter, their serum retinol vitamin A will be falsely depressed. If the CRP climbs past 10 milligrams per liter, serum vitamin D drops. And once CRP exceeds 20 milligrams per liter, serum zinc appears functionally deficient.
It's all an illusion.
You cannot interpret a micronutrient panel in a vacuum. If there is active inflammation, the numbers are distorted.
But, I mean, if the liver is manipulating these gauges and hiding nutrients from the bloodstream, it must be doing so for a strategic reason, right? What is the immune system trying to accomplish by pulling these resources out of circulation?
It is executing a strategy of targeted starvation against the pathogen. And the most critical battleground for this is iron.
Ah, the iron paradox.
Almost all living organisms, including invading bacteria and parasites, absolutely require iron for DNA replication and survival. When the human host detects an infection, it intentionally sequesters its own iron.
It hides it.
It lowers serum iron levels and simultaneously upregulates ferritin, the storage protein, to lock the iron away inside the cells. The host is purposely creating an anemic environment in the blood to starve the invading pathogen.
So the low iron on the lab report isn't a malfunction, it is a highly evolved defense mechanism. Which means if a clinician sees that low iron and immediately prescribes an iron supplement, they are stepping right into a biological trap. It's like dropping supply crates into a war zone. You might accidentally be feeding the enemy.
That is exactly what happens. The textbook explicitly highlights the danger of routine, universal iron supplementation. in regions where certain diseases are endemic. Providing exogenous iron during an active infection can drastically stimulate the growth of pathogens like salmonella and significantly exacerbate the severity of malaria.
Because the pathogen takes the free iron you just administered and uses it to multiply.
Exponentially.
So how is a clinician supposed to navigate this if the blood tests are lying to them?
You have to look for the fire alarm. You must measure acute phase proteins, like CRP, alongside the micronutrients. If the CRP is elevated, you apply established mathematical adjustment factors to the lab results to estimate the patient's true physiological status. You have to assume the iron is hidden, not missing.
But this hijacking goes beyond just blood labs. The sources detail how chronic infections physically halt a child's structural growth, leading to severe stunting.
We see this profoundly in cases of environmental enteric dysfunction, which is a condition driven by chronic gut inflammation often found in developing regions. The persistent exposure to fecal pathogens in the gut creates a localized, continuous stream of those pro-inflammatory cytokines.
Right.
This chronic inflammatory state elevates systemic cortisol and triggers the release of inhibitory signaling molecules, primarily fibroblast growth factor 21 or FGF21.
And what makes FGF21 so devastating in this context is that it literally blocks the nutritional anabolic drive. It acts directly on the bone growth plates to halt endochondral ossification. It does not matter how many high-quality calories you feed that child. As long as FGF21 is elevated by chronic infection, the bone refuses to grow.
The metabolic logic behind it is ruthless. Building bone architecture requires a colossal investment of biological resources. When the body believes it is in a perpetual state of infectious warfare, it refuses to spend those resources on structural growth. Survival takes absolute precedence over development.
Wow. Okay, so to really round out our clinical understanding of the triad, we have to look past basic vitamins and minerals to the microscopic metabolic environment, specifically the gut microbiome and cellular amino acids, which serve as the ultimate modulators of infection.
Absolutely. The gut is not just a digestive tube. It houses the gut-associated lymphoid tissue, or GALT, making it the largest immune organ in the human body.
The largest.
By far. And the mucosal immune system is in constant chemical dialogue with the trillions of bacteria living in the microbiome. Prebiotics and probiotics significantly alter mucosal and systemic immunity.
There's a fascinating example of this in the book involving the influenza vaccine. We know that as patients age, their adaptive immune system blunts, making vaccines less effective. But researchers took a group of elderly, bedridden patients and administered specific prebiotics before giving them an enteral flu vaccine. The patients who received the prebiotics demonstrated significantly higher seroprotection rates to the H3N2 viral strain. They mounted a stronger adaptive immune response just by tweaking the gut environment. How does fiber in the gut translate to better T cells in the blood?
Well, the bacteria in the gut ferment those prebiotics and produce byproducts called short-chain fatty acids, or SCFAs. These SCFAs don't remain confined to the intestinal tract. They're absorbed into systemic circulation and act directly on G protein-coupled receptors located on the surface of immune cells throughout the entire body.
So the microbiome is basically digesting fiber and turning it into a systemic signaling hormone that dials up the functional capacity of neutrophils and T cells. The bacteria are directing the human immune response.
It is a profound symbiosis, and the immune cells themselves require specific ammunition to follow those orders. We traditionally view amino acids simply as the building blocks for muscle tissue, but in the context of immunology, they are chemical weaponry. Take arginine, for example.
We mentioned earlier that macrophages destroy pathogens by generating an oxidative burst, but they also use a distinct chemical called nitric oxide.
Arginine acts as the biological substrate for the production of nitric oxide. If a macrophage engulfs a bacteria, it requires nitric oxide to execute its cytotoxicity, its ability to chemically dissolve the target.
Okay.
If the local cellular environment is depleted of arginine, the macrophage is effectively firing blanks. It has the target trapped, but it lacks the chemical ammunition to neutralize it.
And while arginine provides the bullets, glutamine provides the fuel. While most cells in the human body run primarily on glucose, rapidly dividing immune cells, like lymphocytes and macrophages, actually prefer glutamine for their respiratory fuel during an active threat.
Exactly. If glutamine levels crash, the clonal expansion we talked about at the very beginning, the rapid multiplication of the immune army, simply cannot happen.
Finally, we have to address intracellular defense. which relies heavily on glutathione, or GSH. Glutathione is a vital tripeptide antioxidant and becomes the deciding factor when dealing with pathogens that have evolved hide inside the immune system itself.
Pathogens like Mycobacterium tuberculosis or HIV, they don't just evade the macrophage, they deliberately infect it and set up camp inside.
To clear an intracellular infection, the immune system absolutely must mount a coordinated Th1 response.
Yes, which is driven by cell-mediated destruction. However, the textbook highlights that if a patient's glutathione stores are depleted, a physical shift occurs in the immunological pathways.
A shift.
The system abandons the highly effective Th1 response and defaults to an ineffective Th2 response. The pathogen is allowed to survive simply because the antioxidant precursor was missing.
So what does this all mean? It means nutrition isn't just about avoiding scurvy or anemia. It is about providing the exact biochemical precursors, the arginine for nitric oxide, the glutathione to maintain a Th1 response, the vitamin E to shield the membranes that ensure the biological machinery can actually execute its chemical warfare.
The interconnectedness of this triad is inescapable. Malnutrition, whether it is the M1 inflammatory shift seen in obesity or the energetic triage seen in anorexia, fundamentally compromises the baseline defense.
And conversely, an active infection dramatically distorts the host nutritional landscape, deploying the acute phase response to hide critical nutrients and manipulating iron transport to starve the invader.
Right.
So, to quickly summarize for you, the core clinical takeaways are the triad's interconnectedness, the danger of the acute phase response masking true nutritional labs, the M1 and M2 shift in obesity, and the paradoxical iron withholding. As promised, let's cement this with a quick clinical review exercise.
Let's do it.
You are standing on the ward reviewing a patient's fresh lab results. The panel shows critically low levels of serum vitamin A or retinol and low iron. Before treating a patient showing signs of low vitamin A or iron, what specific acute phase protein must you check to ensure the active infection isn't just hiding the nutrients, and what is the threshold level?
Think about the liver's response.
The answer is C-reactive protein, or CRP. And the threshold to watch out for is anything greater than 5 milligrams per liter. That's the point where vitamin A begins to artificially drop.
This raises an important question, though. We're entering an era of terrifying antibiotic resistance. By understanding this triad, we can ask revolutionary questions. Instead of relying purely on traditional pharmacology to kill a superbug, could we deploy targeted metal starvation, like artificially manipulating iron or zinc availability at the cellular level to starve the bacteria?
Wow, yeah.
Or could we use precise microbiome engineering utilizing specific prebiotics and SCFAs as a primary therapy to hyperactivate the host's own cellular defenses?
It takes that clean, simple X-ray of a broken bone we started with and replaces it with a dynamic, constantly shifting biochemical battlefield. The next time you look at a set of lab values, remember that you might just be looking at the shadows cast by an immune system actively fighting a war. Question the gauges, look for the acute phase response, and always consider the physiological strategy behind the numbers. Take these insights into your studies and your clinical practice. Keep investigating the mechanisms. Until next time.